Uh, Good morning, ladies and gentlemen. I am Dr. Clarence. I am a urological surgeon and a kidney transplant surgeon. Previously, I worked in Hospital Kuala Lumpur, but now I am based in Kuching. We don't do kidney transplants in Kuching yet, but I have my colleagues, Dr. Mulari Sundram and Dr. Vijay and Dr. Yap Yok Chin, who are in Hospital Kuala Lumpur, who has contributed to this presentation. I have many friends in Asia, and I am very much honored to be able to speak to you. This lecture is pre-recorded, but I will log in during the day itself so that we can have some live discussion. This is some background to transplantation in Malaysia. The first transplant was done in 1975 on a young man from Kuching, my hometown, and he got the kidney from the younger brother, and the kidney survived for more than 30 years. And these are the figures in the earlier years of transplantation in Malaysia when I was more actively involved. These are the updated figures from my colleagues from Kuala Lumpur, Dr. Mulai Sundram, Dr. Vijay, and Dr. Yap Yok Chin. And on average in Malaysia, we do about 60 transplants per year. That means about once a week, and about a third of them are from the deceased donors. So what are the surgical aspects of kidney transplantation? The first important component is the artery. So the renal artery is connected. In the living related, we often tend to put it into the internal iliac artery, or you can put it into the external iliac artery or the common iliac artery, external and common iliac artery. And in the deceased donor, we have a carrow patch, and we can put it usually into the common iliac artery so that there is a wide anastomosis. The renal vein is often put into the external renal vein. So the vascular anastomosis is a very important component. I don't know how many surgeons are there in the audience, but I just show you two photographs of the transplant. Of course, this is the transplant kidney. And this shows this part of the kidney is not vascularized yet because the polar vessel has not been connected. Usually, I connect it to the inferior epigastric artery, or sometimes we can connect it to the internal iliac artery. And this shows the ureter with the preserved pad of fat around the renal artery, the renal vein. So the surgery itself, in ideal situation, is fairly straightforward. But now we're having complex recipients. We have more patients who are diabetic, who are elderly, and they're atropathic. So it's very important for every transplant, every surgeon to examine the patient before transplant. We examine the peripheral pulses, especially the femoral pulse. Of course, patients come to us with obvious atropathic, like below knee amputation, gangrene, calcified aorta, absent pulses. Then, of course, this is very obvious, And if you operate on such patients, if the vessel is obviously grossly atherosclerotic, then the bleeding is uncontrollable. Even if you have an extra sucker, an extra nurse, extra vascular clamps. And of course, these patients with kidney failure, they may be also on anticoagulant, and bleeding can be a very serious problem. Now I show you some cases of increasing number of cases of atherosclerosis. So this atherosclerotic aorta, external iliac, common iliac. So this patient is not suitable for transplantation. This is another patient. The pictures courtesy of Dr. Mulari Sundram, gross atherosclerosis of aorta, external iliac, and this is another patient. The external iliac, common iliac are grossly atherosclerotic. So these patients are rejected for transplantation. So most patients have a CT scan done, most recipients, and if they have obvious features of atherosclerosis, then you have to be extremely careful. This particular patient also had atherosclerosis, but the external iliac seems to be spared, and so in some cases we explore the recipient first before opening up the donor. We also diagnosing aortic aneurysms earlier nowadays, and we also have vascular surgeons who put all kinds of stents, endovascular stents, and if this endovascular stent extends to the external iliac artery, then it is very challenging to find a segment of the external iliac artery where you can put in the renal artery. The vein is usually no longer a problem, unlike in the earlier days when I was doing more transplants, because in those days we tend to put in a femoral catheter for dialysis. Now it's used as a last resort, and anyway, most patients will have an ultrasound Doppler or even an angiogram to make sure that the femoral vein, iliac vein, and iliac vessel, iliac veins are patent. It's not a big problem nowadays, but something you have to bear in mind. And finally, often forgotten aspect of a complex recipient is the bladder. So if the bladder is high pressure from a neuropathic bladder, a spina bifida, or posterior atrial valve, or reflux, some of them even have cystoplasties, the bladder is thickened. So if you transplant into a unhealthy, a hostile bladder, then the hostile bladder will also damage the transplanted kidney. It's a matter of just years, a few years. So in such patients, we must make sure that the patient have got a low pressure bladder. Some of them may have associated CACUTs now with good pediatric care and pediatric nephrology care. Many of these patients come on to renal failure and transplantation. In such cases, we prefer to do a submucosal tunnel, so there is more anti-reflux unlike in adults. And of course, we usually put a uteric stent nowadays when we do kidney transplantations, even in adult. So these are some examples of hostile bladders. This is a patient with a posterior atrial valve, post-valgration. This patient was spina bifida, and this patient in some Asian environment where the pediatric surgical care is hazardous, we sometimes do a vesicostomia when the patient has got either posterior atrial valve or neuropathic bladder to allow the patient to grow. And this is a patient with fertile bladder with bilateral hydronephrosis. So if you transplant into this bladder, first, technically, it'll be difficult to form the anastomosis. Secondly, the pressure will be high. So this is another patient with gross reflux, and such patients can have recurrent infection after the transplantation. But nowadays, we don't do that much of open surgery, open reimplantation. We tend to treat these patients with minimally invasive surgery with injection of deflux into the ureteric orifice. We inject into the ureter. So it's an injection technique to reduce the reflux such that the patient have less of a febrile UTI. So how do we know that the bladder is safe? First, you have to have a proper evaluation, including the history. Some of these patients may be producing very little urine, so they may be anuric. So we need to examine the patient as well, the bladder, the penis, the spine, do a rectal examination, and imaging is very important. Okay, imaging is very important. Look for hydronephrosis, look for thickened bladder, although sometimes the changes are very subtle, especially if the patient is no longer producing urine. If the patient is producing urine, we can do a non-invasive urodynamics, that is to do uroflowmetry and measure the residual volume. I think every patient with a neuropathic bladder or lightly neuropathic bladder must have an invasive urodynamics, usually starting with a cystometry, and many of them will end up with a video urodynamics to ensure that the bladder is safe for transplantation. So this is another patient of mine. She had a posterior atrial valve with high pressure bladder, non-compliant bladder with a fertile bladder. So if you transplant into this bladder, it's going to fail. So we did a cystoplasty on him, a clamp cystoplasty. We take the small intestine, we bivalve the bladder, and we patch it on top of the bladder. Okay, and the bladder pressure comes down to almost normal. But many of these patients also cannot pass urine. So they must be willing and able to do clean intermittent self-catheterization before the transplantation. The other forgotten thing in the developing country is that of urethral stricture or urethral damage. We still have a lot of trauma in Asia, especially fractured pelvis. And if the patient is not producing much urine, we often forgotten that the patient has a urethral stenosis. So this must be managed appropriately, sometimes with urethroplasty before the patient actually goes on to surgery. Now we come to the abdomen. So we have dealt with the artery, the vein, the bladder. So the abdomen must be able to receive the kidney. So if the abdomen has got a huge cyst, especially the polycystic variety, there's no space. If the patient has got hydronephrosis from stones, or the patient has got recurrent infection from stones or reflux, or if the patient has multiple previous surgery, then this is also a hostile abdomen. So you cannot put in the kidney safely. So this is one such patient. He has got poor vascular access. The neck veins are also thrombosed, and he went for transplant, and the transplant also thrombosed. So this is a very tough case. This is another patient, started as a pediatric patient with us. I think she was under the care of maybe myself and also Dr. Susan Wu. He had a urethrostomy, had a left nephrectomy, had a urethric implantation, and had a difficult cystoplasty. So this is considered like a frozen abdomen, not friendly to transplantation. This patient that I saw recently with gross abdominal distension with ventral hernia. So there's no space to put the kidney. So usually we need to take out at least one kidney, usually the right side. Or if there are any suspicious cysts, Bosniak 3 or 4, so it's better to remove them before transplantation. But not all patients require a nephrectomy. It's not a routine. Only when there are certain indications, infection, suspected malignancy, bleeding, then we subject these patients to a nephrectomy, and also it's not easy nephrectomy, not easy to do by laparoscopy. So what are the indications for native nephrectomy? If there is not enough space, if there's infection, and unfortunately in Asia, I think up to 5% of kidney failure are due to stones by obstruction. Sometimes, we know that kidney failure patients, dialysis patients have more neoplasms. When do we remove the kidneys? We can remove at the same time. Although most people prefer to stage the operation, we remove the kidneys a few weeks earlier. And if the kidneys are removed for confirmed cancer, then we have to wait for a certain time, usually about 2 years, for us to move on to a transplant. So finally, we talk about the patient. Which are the patients with complex recipients? In my mind, the first group are the pediatric patients. Of course, we have patients with, now we have got more patients with comorbidities, with coronary artery disease, older patients, frail patients, cancer survivors, and also patients with likely recurrent nephrological disease, patients with coagulopathies. This is the patient factor which will affect the outcome of the kidney transplantation. Although not strictly surgical, it's very closely related to surgical outcome. So we talk about pediatric patients. In Asia, there are not that many pediatric transplants. Most of the patients are treated by peritoneal dialysis or by hemodialysis, except in some countries like Japan, Jordan, and UAE, they have got more pediatric transplantations. And these are the absolute figures given to me by Dr. Yap Yok Chin. We maybe have about less than 10 transplants per year, and we have a good number. Maybe 50% of them are from cadaveric donors. And but this group of patients, they are the complex patients. They don't grow well. It's difficult surgical access. The fistulas are small. The perm cath tend to get infected, thrombosed, and if you do peritoneal dialysis, they often have hernias. So they are difficult. They are difficult from the surgical point of view as well. The artery are small, although we often try to use the common iliac artery. The veins are small, and if they are very tiny, and the patient is transplanted for some medical urgency, sometimes we have to use the aorta or the IVC, and in such cases, we have to call in the vascular surgeon. In Malaysia, the transplants at the moment are all done by urologists. So the anastomosis must be meticulous. We often have to use ocular loops, and even then, sometimes the space may be too small for a big adult kidney. So in the early postoperative period, if they have oliguria and there's decreased perfusion, the patient may be having a compartment syndrome. So you have to open up and release the pressure on the kidney. I mentioned earlier that if we transplant into a pediatric or a neuropathic bladder, we prefer to have a tunnel to reduce the reflux. And I think for most transplants nowadays, whether it's difficult transplant or pediatric transplant, we usually put in a double J stent for temporary splintage of the reimplantation to reduce the factor of obstruction if there is a complication. Because of the differences in the body size and blood volume, it's important to keep the blood volume higher, the blood pressure higher. I think the smallest transplant we have done in Malaysia, I think is either 15 or 17 kilos. So generally, we prefer the child to be about 20 kilos. The overall survival, graft survival is very good. All these data on kidney transplantation, on dialysis, are available in the Malaysian renal registry, and the 5-year survival is 90%. The results are good. I look around for other categories of complex transplantation, and we know that we have older patients above 65. They have comorbidities, and in one such study reported in the American Journal of Kidney Disease, The 10-year survival for older patients, I won't say elderly, older patients, is 32.3 years compared to 72.3 in the younger patients. This report, of course, is older, is in 2013. There's a report from South Korea covering the period of 2016, and they have looked at 14,000 transplants in South Korea. And again, diabetes is an important contributor, especially in Asia, especially in Malaysia, 35.6% in 2016 in South Korea. But nevertheless, despite the comorbidities, despite the so-called elderly, the 10-year graft survival is 77.6%. So it shows that with meticulous attention, complex recipients are successful. And as a surgeon, we also have to follow surgical guidelines meticulously in the preoperative evaluation and also in the operative care of these patients following international guidelines. So we'll look at the artery, we'll look at the vein, we have to look at the bladder, especially the bladder. We have to look at the abdomen, and in the special groups, we have to take special precaution surgically and medically to ensure a good success, and it is viable. So this is my last slide. I hope you enjoyed the Asian transplant meeting. I'm speaking to you from Kuching at the tip of Borneo, but of course now with internet, we can reach out to each other. And I'm not sure how the Q&A will be conducted, but I'm happy to discuss any Q&As on my email and on my WhatsApp. I don't use so much of Twitter and Facebook. So thank you for your attention.